out, well, I'll show you a picture of it. I used to get annoyed at people who showed pictures of their hospital. Can we turn that light on?
You need to turn it on up there with the two focus buttons at the same time.
Oh,
That'll turn
yeah, we don't want that light, those lights, yeah. Well, this is Baylor University Medical Center, and everybody knows about Baylor in Houston, the Baylor College of Medicine, but actually Baylor College of Medicine was started here at Baylor University Medical Center in the early part of the century, and Baylor University sold the medical school to Houston in 1943 when Southwestern, University of Texas, started in Dallas. Dallas at that time was 240,000 people, so they were afraid it couldn't support two medical schools. It still has a dental school, and actually it's the only hospital, as far as I know, that is connected to a university that doesn't have a medical school now. But it's a large place, and it's a very friendly atmosphere. They have I would say a very progressive administration. The number of people that are board certified on their staff is virtually 95%. So it's a nice place. I've been, I loved NIH, and I like this place very much. It's a nice change. I feel lucky at my age to start a new career. We're involved in trying to build a cardiovascular institute. Every hospital seems like is trying to do that right now. But there are a lot of positives and a lot of reasons for doing that. I think medicine today, divided into pathology department and medicine department and surgery department, is archaic in many ways. The organ should be the central thing, and it should be hit by cardiologists if it's the heart, and cardiac surgeons, and cardiovascular pathologists, and cardiovascular radiologists. And I think the patient is the winner when that's the situation. My chief of medicine doesn't like me to say that. We have an editorial in the American Journal of Cardiology this week, October 15, discussing that item. Should cardiology be a subspecialty or a department? It's really it's an item which is causing a lot of discussion these days. Now, this is a coronary artery, and unfortunately, if you look at that person next to you, one of you is going to die from atherosclerotic disease. Now, I know it's the other one, not you, but this is the major disease problem facing the Western world, of course. It's a situation, I think a lot of people think coronary disease is an old person's disease. The average age of death in men from coronary disease is 60, age 60. That's without coronary bypass or coronary angioplasty. Coronary disease is also the most common cause of death in women as well as men. It's interesting, however, that in women, it takes till a decade, 81 to 90, before more men die from coronary disease than women. I think the reason for that is the men died early. And before age 60, actually, nearly 90% of the deaths from coronary disease are men. And the problem here in the early years is sudden death. Sudden death is a problem of young men. I think that's one of the reasons so many of us, or so many cardiologists or other people, think that coronary disease is a disease of old people. But these young men that died, they go to the medical examiner's office. They don't go to the hospital. They don't even see a doctor. A lot of them anyway. But 60. In women, the average age of death without angioplasty or bypass is 68. My colleagues and I, a number of years ago, looked at these various subsets of patients with coronary disease and asked a simple question. What we were trying to get at is that although clinically these various subsets are quite different, the question asked, do they have the same amount of coronary narrowing or different amounts of coronary narrowing? Well, when we looked at the four major coronary arteries, the right, the left main, the left anterior descending, left circumflex, and asked a simple question, how many of these four arteries are narrowed at some point greater than 75% in cross-sectional area? The answer was 2.7, and there was no significant difference among these various subsets. So here you've got clinically a very different variety of patients. And yet, by atherosclerotic disease, they have the same amount of coronary narrowing if you look at it from that standpoint. How many arteries are severely narrowed at some point? Well, being a bit annoyed at not finding a difference by that approach, we started looking at the coronary arteries this way. By taking these arteries off the heart intact, treating them gently, fixing them, taking them off, put them in a little container by themselves. Then after they're fixed, bringing them out and cutting them at 5mm segments. If they were calcified, decalcifying them first, changing the knives about 10 times during the cutting of these so we wouldn't crack a plaque. And then asking the simple question, how many of these little bitty 5mm segments are narrowed to this extent and this extent and this extent? Would there be any differences if we could look at the entire coronary tree? Well, one of the groups we looked at was a group, sudden coronary death. Now, the typical patient here is the patient, the man, relatively young, who's watching television and suddenly he's not watching anymore. I mean, that's a typical scenario. Well, the right coronary artery is normally about 10 centimeters long. The left main's about 1. The left anterior descending in general is about the same length as the right. Left circumflex is about 6 centimeters. So that produces 27 centimeters of coronary artery. Since we divided each centimeter into two 5mm segments, that produces 54 or 55 5mm segments per person to look at. And then we asked, how many of those little segments are narrowed 76 to 100%? The latest studies, we used to divide them 76 to 95% and then 96 to 100% to get that group that were virtually totally occluded out of the way. The point of all this is about a third of the lengths of these arteries are narrowed over 75% in cross-sectional area. I'm talking about cross-sectional area units, not diameter reductions, the units of angiography. That is, if you have a circle divided into 4 quadrants, over 3 of them are obliterated. 1/3 of the coronary tree. Another third narrowed 51 to 75%, and only 7% of the segments even approaching normal, and not a single one normal. When I was in medical school, I was taught coronary atherosclerosis, focal process. You see it in one artery, don't see it in another artery. See it in one spot in one artery and not in another spot in that artery. Folks, that's a myth. Now you might say, well, these are patients who died from coronary. That's not my patients. I'm not so sure. There's a lot of evidence that there's not much difference in the amount of narrowing in the coronary tree in the patient with symptomatic myocardial ischemia versus the patient with fatal myocardial ischemia, unfortunately. Now we looked at, it turned out that the patients with sudden coronary death and acute myocardial infarction had similar degrees of coronary narrowing by atherosclerotic plaque. And in both of those groups, if you look at the 4 coronary arteries and ask what percent of the segments are narrowed, 0 to 25, 26 to 50, and so on, in these 3 arteries, the left circumflex right, left anterior descending, the amount of narrowing at all 4 categories of narrowing were similar. And that's the way it is in all subsets. Now this is pooled data. First we pooled 31 patients, and then we pooled 100 patients, and it was the same. In the left main, only 10% of the segments in these sudden death victims and in the acute myocardial infarction victims were narrowed greater than 75%. Now, how big does a group have to be before you get this similarity in these 3 arteries? Well, you can't predict it precisely in a single patient, but with a group of only 3 patients, that's the way it works out. Now this is based on a group of patients with unstable angina. Now, not many patients with unstable angina die. Most obviously go on to have angioplasty, or they have bypass operation, or they have an acute myocardial infarction, and then they're not a pure unstable angina group. This particular study was based on a group of patients, 22 patients, who had unstable angina. That was the only manifestation during life of myocardial ischemia. They had a bypass operation and they died within 7 days. So this is a group of patients whose natural history was actually interrupted. We subsequently studied 35 patients who died during unstable angina without angioplasty, without bypass, and without acute myocardial infarction. And the same thing was found. Unstable angina group, the worst coronary narrowing of all. Nearly half of the lengths of these 4 arteries narrowed greater than 75%. And yet this group of people, the best myocardial function, good ejection fractions, no congestive heart failure, no myocardial necrosis, the worst coronary narrowing of all. When I'm a so-called visiting professor and walk into those coronary care units and see that patient over there with unstable angina, boom, I throw up a red flag. I look at that person and say, I wonder if that individual knows that on the average person, that 50% of that coronary tree is narrowed over 75% in cross-sectional area. Good function, but the worst narrowing. I would move more aggressively on the unstable angina patient than any patient. They got good myocardium, they just got terrible coronary arteries. Now this is this quantitative data I've been talking about. Just look at this column here, this very busy slide. But by this quantitative approach, we were able to show some differences. The sudden coronary death, acute myocardial infarction group, no differences. That is, no differences in the amount of narrowing by plaque alone. Patients with a healed infarction, a little less. Now, that 31 and 34 and 36 don't look like much difference, but when you're dealing with 6,000, nearly 500 segments, that was significantly different. And then the patients with unstable angina, terrible, the worst of all. Total 35% of the coronary segments, and you paid for this as taxpayers, thank you. 35% were severe than that. Coronary disease in patients with symptomatic and fatal atherosclerosis, coronary disease or myocardial ischemia, is a very diffuse process. I think all of us from looking at angiograms think it's not so, because here is a lesion. The implication is there's no lesion elsewhere. This is a lesion, this is a lesion, this is a lesion. Folks, that word lesion, as an editor of a medical journal, I try to change that word lesion to narrowings. I get defeated a lot. But there are lesions everywhere. There are some lesions that are just much bigger than others and cause more luminal narrowing than others. But it's a very extensive, diffuse process. Now this is a montage of coronary arteries in a patient with unstable angina. Each one of these histologic sections of photomicrographs represents a single section of a 5 millimeter segment. Now let's go down this right coronary artery and try to find one that's normal. Here's the left main, terribly narrow. Left anterior descending. Now if you blown up a balloon in this patient, where would you blow it up? Blow it up here, 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 here. Why not? Heart flow may be right. Left circumflex, look at this. This was dominant artery in this patient, all the way out to here. Phew. That's what the patient, and that's what you are up against with coronary disease. And to believe otherwise is to believe a dream, folks. Now, I know you folks don't look at cross-sectional areas that are shown here. You look at patients with 1, 2, 3, 4 vessel disease approach by angiogram. And what this slide attempts to do is that if you take the average patient by angiogram who has 1 vessel disease, that means that there's more plaque in one artery than in the others. It does not mean that the other arteries do not have plaque. It simply means they have less plaque. But if you take all the 5 millimeter sections of all these arteries in the patient with 1 vessel disease, 40% of the lumen is obliterated by plaque and 60% is lumen. In the average person with 2 vessel disease angiographically, the quantity of plaque is greater, and now we're at a 50-50 situation. 50% lumen, 50% plaque. Person with 3 vessel disease, the quantity is even greater. Now we're at 40% lumen, 60% plaque. In the person with 4 vessel disease, and most of these patients are unstable angina, the quantity of plaque is really enormous. Now we're at 70% plaque, 30% lumen. A pretty bad process. Question 1, how much luminal narrowing is present in patients at least with fatal coronary disease? The answer is a lot. Question 2, what do these atherosclerotic plaques consist of? Anybody? What do they consist of? You're the first audience I've ever heard that answered it that way. Well, that's the answer. Now, most people say fat, cholesterol. Now, these are in patients with fatal coronary disease. Now, most of these studies were done by a colleague in my lab about 3 years ago, Amy Kregel. And what was done, these 5 millimeter sections were taken and put on a fancy computer projection system, and it would project the coronary artery on the screen, and then you'd take this computer pen and you could easily trace out the amount of dense fibrous tissue in the plaque and cellular fibrous tissue and calcified and so on. It was very fancy. And then the computer would read off to you that 33% was this and 67% was this. Well, what is shown here is a group of patients over 40 years of age with fatal coronary disease. And what we're seeing here are the little plaques and the big plaques. And down here is the amount of cross-sectional luminal narrowing produced by the plaques in that 5 millimeter section. So here, the amount of luminal narrowing was minimal. In other words, this little 5 millimeter section, it was mainly lumen, it was wide open. In this 5 millimeter section, the lumen was narrowed 96 to 100%. In other words, the plaque here was huge. Now, what did we see? We saw that as the plaque got bigger, now all of these patients died from coronary disease. We're not talking about plaques in people 15 years of age or 20. As the plaques got bigger and bigger, the amount of dense fibrous tissue got greater and greater. Now, dense fibrous tissue essentially means acellular fibrous tissue. The amount of cellular fibrous tissue decreased. The amount of calcium increased as the plaque got bigger. Pultaceous debris increased as the plaque got bigger. Now, what in God's name is pultaceous debris? Well, that's extracellular lipid. This is reversible experimentally. That was present only in the big plaques. And foam cells were very, very infrequently seen. These little plaques over here, what did they consist of? Where is all the lipid? They didn't have any lipid over there. This was all cellular fibrous tissue. So the answer to the question, what are atherosclerotic plaques in coronary arteries? It may be different in aorta. What do they consist of in patients with fatal coronary disease? The answer is primarily fibrous tissue. Now, the question asked in this study is, are there any differences in plaque composition among the subsets of coronary patients. Now, these patients with acute myocardial infarction, sudden coronary death, and unstable angina, all these patients here were over 40 years of age. We did another study in a group of 8 women who died in their 30s from various coronary events. So we used them as the comparison for this group, although they were different sex. But what we see is the answer to the question is yes, there are some differences in the various subsets. The patients with acute myocardial infarction, and these were all men, they were all over 40, the mean age in each group was the same. The patients with acute, and these are just the big plaques. These are plaques causing luminal narrowing over 75%. The little plaques are eliminated here. The acute myocardial infarction group had a larger percent of extracellular lipid. Now, is that important? Well, there's a good bit of evidence experimentally that the more extracellular lipid is present, the greater the clotting tendency. So these groups, of course, have by far and away the largest percent of visible thrombi, at least at necropsy. So, and the sudden death group and the unstable angina group were similar. At least no significant differences among any of these subsets. The other thing to notice about this, in these big plaques, there were essentially no foam cells in these people over age 40. Now, foam cells are completely reversible. These women under age 40 had a lot of foam cells. Now, the way I look at this slide is that we're in this period of reversibility. You get the cholesterol level way down and the plaques shrink. Well, it looks to me like that if you're dealing with young people under 40, that the chance of reversibility is greater than in those over 40, less than 1. Number 2, it looks to me like that the patients with acute myocardial infarction have more lipid than the patients with unstable angina and those with cardiac arrest. So maybe you've got a better shot at reversibility in them. Dr. Robert Whistler in Chicago believes that some of this cellular fibrous tissue, shown here in red, is reversible. So the answer to the question, yes, there are little differences in plaque composition among the various subsets of patients, just as there were some differences in amounts of luminal narrowing among the various subsets. Now, the question asked in this study, and this was done by Dr. Susan Maltner in my lab at NIH, the question was, is there any difference in plaque composition in women and in men? So, this study was set up comparing women and men, and it turned out that all these patients had bypass operations. So we could compare the native arteries and the saphenous veins age to age, men and women. And men, the code's different here. Now red represents dense fibrous tissue and yellow represents cellular fibrous tissue. And men have more dense fibrous tissue than women. Cellular fibrous tissue is softer. Women are softer. That's the way to remember that. Now in saphenous veins, the same thing held true. And this was the same age period here, or same average from operation to death. And women had more cellular fibrous tissue in their saphenous veins than did men. Now the question asked in this study is, what is the relationship of plaque composition to time interval after bypass operation? And what we see here are the native coronary arteries, and there was no difference at any point up to 26 months, 27 to 81, or after 82 months in plaque composition in the native arteries. Well, nobody would really expect differences there. And what was found in this study, which I think is of interest, was it really took 82 months before the plaques in the saphenous veins looked the same as the plaques in the native arteries. There's a lot of discussion these days on what precipitates acute myocardial infarction. What causes someone to suddenly have cardiac arrest? Are we dealing with a crack in a plaque and then a thrombus forms right on top of that crack in the plaque? There are a lot of people now who think that this information is done, it's settled. I'm a little hesitant in this regard. I think it's very difficult to read crack in a plaque from a coronary angiogram. I don't think a diagnosis of thrombus by coronary angiogram would hold up in any court in any land. So I think we have to be a bit careful. Now this study, which was done in my lab, again by Dr. Amy Kragel primarily, is a relatively small study, but it's a pure one. And what I mean by that is we took a group of 67 patients who died of these 3 coronary events here. Now each of these events was the first coronary event in each of them. They weren't contaminated, in other words. The people with unstable angina had no myocardial necrosis and they had no healed infarcts. The people who died suddenly, sudden coronary death, had no myocardial scars, no myocardial necrosis, and they never had a history of angina pectoris. The patients with acute myocardial infarction, this was their first and only coronary event. No myocardial scarring, never previous angina, never previous non-fatal cardiac arrest. So we asked, among these acute lesions here, what was their frequency? And this was in patients. And this has been seen by a lot of people. Frequency of thrombus, much higher in acute myocardial infarction, similar in these other 2 groups. Interestingly, this is the highest frequency of thrombus in any group of sudden death cases we've ever seen, or at least I've ever seen in 32 years. This was a 21 patients studied at the same time these were. In most of the other studies, this was 19% or 10%. But at any rate, similar in these 2, very different here. Plaque rupture, similar, no significant difference in these 2, much higher here. Plaque hemorrhage, much higher here, same here. Multiluminal channels in regard to patients, no difference. Now if we, well, I took that out. If you look at that by 5mm segments and ask from a 5mm segment approach, what's the frequency of thrombi, plaque rupture, plaque hemorrhage? It's the same in all 3 of these. So it depends how you phrase the question, what kind of answer you're going to get. By 5mm segments, multiluminal channels, and this means previous organization of thrombi, probably, that was significantly higher in the unstable angina patients than the other 2 groups. Yes?
Why did the unstable angina patients die?
I don't know. These were, they died, they were all in the hospital, and they came in for unstable angina, and they didn't go on to angioplasty or bypass, and they had no myocardial necrosis. So it's a pure group. They just had cardiac arrest there on the ward without these other procedures. See, if you mix unstable angina group, if you include people who have bypass operation, well, you increase the frequency of plaque rupture enormously. Plaque hemorrhage, I mean, you can get traumatic plaque rupture and plaque hemorrhage from the procedure itself. Same with angioplasty. So, although the numbers are small, the groups are pure as you can get. The study that's quoted the most is Michael Davies' study of a lot of patients. And the criteria for his study, it was labeled unstable angina. This was published in Circulation. And the frequency of these lesions in unstable angina. And how did he define unstable angina? Unstable angina were patients who died suddenly outside the hospital. And they had chest pain within 3 weeks of death. And how was that chest pain determined? The police officers asked members of the family or the person that the victim lived with whether or not that person had chest pain in their last 3 weeks of life. And if they had chest pain, they were said to have unstable angina. And that's the major study quoted. Now, is that unstable angina? You can have chest pain over here. Who knows where that chest pain was? Police officer taking the history. Published in a pretty good journal. That's what we're dealing with. I want to switch gears here to prevention, regression. I've looked at enough atherosclerotic plaques in my lifetime, folks, and I don't need to look at another one. We can prevent atherosclerosis. We don't have to have it. It's genetic in 1 out of 500 of us. 1 out of 500. 1 out of 1,000,000 have the homozygous variety. 1 out of 500 have the heterozygous familial hypercholesterolemia. There are some people who say, well, it's really 1 out of 200. The point is, genetic determination is really relatively small. Now, how many risk factors to atherosclerosis are there? How many direct atherosclerotic risk factors are there? This was a slide from the expert adult panel on atherosclerosis, January 1987. They said there are 10 atherosclerotic risk factors. Are there? Or how many are there? Question: how many direct atherosclerotic risk factors are there? What's the key word in that sentence?
High cholesterol.
Direct is the key word. Now you say high cholesterol. And what do you mean by that? You mean without it you don't get it?
No. High LDL cholesterol.
High LDL. So you don't get atherosclerosis unless you have a high LDL cholesterol. That's what you're saying.
Yeah.
Does anybody else say there are other direct atherosclerotic risk factors?
I don't think you know one.
What?
I don't think you know one direct risk factor.
You don't?
I think oxidized LDL is probably a direct risk factor.
So you're a cholesterol person too.
But it's got to be,
Whether you oxidize it or not oxidize it, you're a cholesterol person.
yeah, that's right.
Okay. Does anybody choose another factor as a direct atherosclerotic risk factor?
Age.
What?
Age.
Age. So you think it's a degenerative disease. As we get older, we get it. Now, can you get older without getting it?
Yeah.
So it's not direct.
Well, most of it is.
Okay. Can you get it at age 30?
Sure.
You can. Can you not get it at age 95?
Yeah.
It's rare, though.
Rare.
No.
So you don't have to be old to get it. Is that correct?
More frequent as you go.
It's more frequent, but direct means you got to have it.
I don't know what I mean by correct.
There's no question.
Nothing's 100%.
Well, I'm not so sure.
Even a shot to the brain is
You mean 100% death?
not 100%. Yes.
Well, there's certain things that are 100%. Well, I agree with the first answer. I'm a cholesterol person, and I don't think you get atherosclerosis unless you get that cholesterol level. Now, you can talk about the LDL, whichever one you want to pick, over a certain number. Systemic hypertension, very important. Major cause of stroke, but if you have a total cholesterol of 130, it's not going to accelerate atherosclerosis. If you have a total cholesterol of 140, 130, 150 maybe, cigarette smoking's bad, but it's not going to accelerate atherosclerosis. There's no question, there's a lot more atherosclerosis in older people than younger people. No question about it. But you don't have to be old just to get it. So I'm a 1 atherosclerotic risk factor person. And I think the multifactorial cause of atherosclerosis throws us off. We lose our focus that way. Now, the cholesterol problem in the USA is a major one. This comes from the Lipid Research Clinic. The man who started this was Dr. Robert Levy, who's head of research at Robbins, and Eric's wife, who's supporting my being here tonight. And this is very important data. This shows what percent of our U.S. population, age 20 to 74, is over 240 milligrams per deciliter. Now, it turns out throughout this entire range, 25% of the U.S. population has a cholesterol level total over that number. Women, after age 55, 50% of the women in this nation have total cholesterol levels greater than 240. Men have higher levels earlier in life, lower levels later. The reason here, I think, is that those with higher levels are now dead. They're not available to compare. But cholesterol levels of 240 is a very high level. Only 5% of the U.S. population have total cholesterol levels over 265. Now, what's the average total cholesterol in your patients when you walk into the coronary care unit to make ward rounds in the morning?
212.
You know, about the average cholesterol level, as I understand it, in patients with acute myocardial infarction first day is 227. Most physicians in the USA do not consider that abnormal. I do. Now, these are the factors linking cholesterol to atherosclerotic plaques. In my view, this is not a controversial issue. The data is in. Now, the question is, do we act on it or do we not? Now, this started in 1908, feeding high cholesterol diets to certain non-human animals. It's interesting that the animals chosen were rabbits. You can give all the fat, all the cholesterol, all the raw red meat to a dog or a cat that you want, and you can't produce atherosclerotic plaques. But if you give it to a rabbit, or if you give it to a human being, you can produce a lot of atherosclerotic plaques. The next thing found was that the biochemist found cholesterol within these plaques. And then not much happened until after World War II, when Ansel Keys and his group got started on the multi-nation studies. I conclude from those studies this sentence: atherosclerotic plaques large enough to produce clinical problems occur only in persons having serum or plasma total cholesterol levels greater than 150. Now, that 150 is an interesting number in my view. If you really want to prevent atherosclerosis, that is, prevent it so that it doesn't get big enough to cause luminal narrowing, that is the number to shoot for. When we are born, I understand our umbilical blood has a total cholesterol of about 75 milligrams per deciliter. Within 2 weeks of life, it shoots up to about 150, and it stays about 150 until we graduate from high school. And then it gradually goes up from there. If we could keep it what it was when we graduate from high school, the health of this nation would skyrocket. Now, items 4, 5, and 6 were really solidified the last decade. The higher the blood total cholesterol level, the greater the chance of having symptomatic atherosclerotic disease, the greater the chance of dying from atherosclerotic disease, and the greater the extent of the atherosclerotic plaques. Lowering the blood total cholesterol level decreases the chances of fatal or non-fatal atherosclerotic disease. Little simple sentence. How many of us are acting on it? It took at least $158 million US to answer that question. If you lower the cholesterol level, can you lower the frequency of heart attack? The answer is yes. Number 6, there are about 8 studies now 5 of them were published in 1990. Atherosclerotic plaques regress or have the potential to regress when high blood cholesterol levels are lowered. In my view, the connection between cholesterol and atherosclerotic plaques is a firm one. It would hold up in any court in any land. This is Ansel Keys' famous 7 nation studies. He studied about 13,000 people, found in certain acreages on planet Earth very little coronary disease. Other areas, U.S., Finland, very high frequency. Ansel Keys concluded this was mainly a cholesterol problem. Southern Japan, about 150. This was data collected in the 1960s. At that time, the percent of calories from fat in Japan was approximately 10%. They're now up to 23%. Finland, it was approaching 300. They're coming down a little bit now. Well, Ansel Keys, you know, his PhD, he wasn't a real doctor. You didn't have to listen to him too much. But Ansel Keys is 90 years old now. He's living on the Riviera, going swimming every day. He's doing fine, thank you. Now this study was published in 1986, Stamla, Mr. Fit, Chicago. Very important study. Why? Look how many people were studied. Over 350,000. All men, sorry ladies, aged 35 to 57. They were asymptomatic when they entered the study. They were divided into 10 groups according to their serum total cholesterol level. And what this study so nicely shows, as that mean total cholesterol level goes up, up, and up, the coronary artery mortality, and this is a 6-year mortality, goes up, up, and up. If it was a 12-year mortality, it's even worse than that. No study shows it better that that cholesterol is a quantity, and the higher that quantity, at least total and LDL, the greater the risk. Now this is the primary prevention trial, meaning trials that in people, these were all men, again, about 4,000 each group. They had very high cholesterols, over 265. It's been shown by, was shown by Blankenhorn and others that you can start at 220 and get the same percentage reduction. So you don't have to have a high level in the beginning to get a marked reduction. But at any rate, both of these studies in asymptomatic men, average age about 47 years, that if you put one group on a lipid-lowering drug compared to another placebo-controlled group, after a certain number of years, 7 years, 5 years, those treated with the drug, or at least allocated to drug treatment, big difference, have a lower frequency of heart attack than the other group. 19% reduction here, 34% reduction here. Now these percentages, in my view, are very conservative percentages. Number one, we have much better drugs today to lower cholesterol than, that is LDL in total, than either of these. Number two, both of these studies were by intention to treat. And although the statistician liked those studies, I don't particularly like them, and I don't think it gives the proper data in my humble view. And the reason for that is 30% of the people in this study, 30% of the people in this study quit taking the drug after 1 year, and yet they stayed in the drug arm throughout the study. If you compare in this study, for example, the people who actually took cholestyramine in the amount that they're supposed to take it every day for 7 years, there was a 25% reduction in total cholesterol, and not a 19% reduction in heart attack, but a 50% reduction. 50%. And today, one can lower total cholesterol, or at least LDL cholesterol, with a combination of an HMG-CoA reductase inhibitor and a bile acid resin, and you can throw in a little nicotinic acid or gemfibrozil if you want to, and you can lower it greater than 50%. That ain't bad. This is a slide summarizing the secondary prevention studies. Now these are people, of course, who had an atherosclerotic event. It may have been a peripheral vascular event or coronary event. But after the event, they all had coronary angiograms, and then they were put on a lipid-lowering regime. It might have been a drug, it might have been a pure vegetarian 6% from calories diet, or it might have been a partial ileal bypass operation. But all of these procedures lowered the total and LDL cholesterol level. And what happened? Repeat angiogram at 1 year, 2 years, 2.5, or 4 years showed that those allocated to drug therapy had marked regression of plaques. Look at the difference compared to the control. The control group had a relatively small regression of plaque, shrinkage of plaque, compared to the other group. Secondly, those treated had a lower frequency of progression. That is, the plaques getting bigger in the 1 year, 2 years, 2.5, or 4 years. Now, do you treat your patients who've had heart attacks, unstable angina, angioplasty, bypass with lipid-lowering therapy? The data is in. It's absolutely overwhelming in my view. This is one of those studies, Greg Brown's study, the FATS study, F-A-T-S, FATS. The reason I show this slide, he had about 120 patients, very beautifully done study. But what the cardiovascular events, this was a 2.5-year study, the cardiovascular events significantly reduced in the treatment group compared to the non-treatment group in 2.5 years, plus regression. He's now treating these patients not with double lipid-lowering therapy, but with triple lipid-lowering therapy in an attempt to get all of their total cholesterol levels down to the 150 milligram range. The reason I like this study a lot is that Greg Brown was a cynic. He was a non-cholesterol believer when he started this study. He thought it was going to be negative. It's overwhelmingly positive. There's no question that reversibility can occur. Granted that lipid makes up only about 10% of a plaque, but if you can suck that out of there to here, you can open up that lumen a good bit. And one of the physiologic principles, as I understand it, is that an artery has to be narrowed over 75% in cross-sectional area. That is, over 3 of the 4 quadrants have to be obliterated before flow is actually diminished. Now, if you can suck some of that lipid out of there, you can open up that lumen so that it is less than 75% narrowed in cross-sectional area. And that is as if there's no narrowing at all. So maybe small changes in plaque mass can lead to very significant changes in lumen size. Let me switch to nutrition. I don't claim to be a nutrition expert. When I was in medical school, I didn't hear a single lecture on nutrition in 4 years. I got interested in this about 1980, and since that time I've been collecting diet books sort of as a hobby. This slide comes from Scott Grundy. It summarizes findings in 3 different groups of investigators. Each show the same thing. If you take a group of people, increase their cholesterol intake, you're going to increase the cholesterol in the blood. It doesn't work that way in everybody. Some people can eat 3 eggs, no change in the cholesterol. Others can eat 3 eggs, and it will shoot up. Some people have great responses to these low cholesterol, low fat diets. Others have no response hardly at all. Some people say, well, we ought to switch from cows and pigs and eat more chickens and turkeys and fish. Well, don't switch from one flesh to another because you're going to get less cholesterol. The amount of cholesterol in all these fleshes in 100 grams, that's about a deck of cards size, is about the same. It's about 85 milligrams. The good thing about fish is relatively little fat. Actually, I don't worry so much about cholesterol. Most of us take in 500 milligrams or less every day. I can tell you that a toothpick weighs 100 milligrams. So most of us only take in 5 toothpicks of cholesterol every day. And all of it, as you know, comes from animals and their products. If we give up eggs, we give up cholesterol. We give up half the cholesterol we take in, visible and non-visible eggs. If we give up the red meat, we give up most of the cholesterol, so it's easy to get rid of cholesterol. Now the fat, on the other hand, is another villain. The average American adult takes in about 140 grams of fat every day, and unfortunately about a third of it is saturated. Let's say we take in 45 grams of saturated fat every day. Well, it just so happens that that saturated fat, when it enters our bodies, it's converted essentially into cholesterol. So our biggest source of cholesterol is not the direct stuff we take in, but that which we take in from saturated fat. And we can change these saturated fats. We need to give up these on this side with coconut oil. That's the pits. Look at that, 92% saturated fat. We need to eat more of these over here. Grundy has some evidence that olive oil, that monounsaturated, is better for us than polyunsaturated. Peanut butter is nearly 50% monounsaturated. All those have a lot of fat in them, a lot of calories, but the difference in saturated fat is enormous. Now, if you really want to get a good grease job, the place to go is the local fast food chain, of course. And these people, Jacobson and Fritchner, went around to the top 15 to try to determine the ingredients of the foods they served. And these are the ingredients of the hamburgers. The Wendy's triple cheeseburger, folks, is the coronary artery bypass special. And it is closely followed by the Burger King double beef Whopper with cheese. We are talking in that single hamburger, about 1,000 calories. And if you take that sucker and squeeze it real hard, you can come up with about 15 teaspoons, not grams, teaspoons of fat in that single hamburger. And much of that is saturated. And this little word here, sodium, is not sodium chloride, it's not salt, it's sodium alone. And here we have 1,800 milligrams, 1,200, 1,300, 1,800, 1,100, 1,600. I'll have the half-pound double deluxe bacon steer burger, please. You want chemotherapy with that? This fellow John Love wrote an interesting book entitled McDonald's Behind the Arches. Probably some of you have heard Bill Castelli talk about this subject. He calls the arches of McDonald's the entrances into the pearly gates, and I think he's right. Look at this one. Slightly more than 50% of the population of the U.S. lives within 3 minutes of a McDonald's. This is an old slide. McDonald's has served now over 80 billion hamburgers, and think how many atherosclerotic plaques. They're the biggest purchaser or killer, whatever your perspective is, of cows in the world. Since they started Chicken McNuggets, they're the second biggest purchaser or killer of chickens in the world, the biggest purchaser of the potato crop in the world. Look at this number 7. McDonald's has employed at one time or another over 8 million workers, 7% of the entire U.S. workforce. And McDonald's has replaced the U.S. Army as America's largest job training organization. They're the largest owner of commercial real estate. It's power. This fellow Tom Parker wrote an interesting book. He asked the question, what do we consume in America every 24 hours? Well, about 815 billion calories of food consumed every day. Roughly 200 billion more than we need. Those 200 billion left over would feed the whole country of Mexico every day. In 1990, folks, we reached 60%. 3 out of every 5 Americans are obese, and 30% are over 30% ideal body weight. When I was at NIH, I used to ask people who walk in my office. We had a lot of foreign visitors. What strikes you most about Americans? Well, of course, that produced a lot of different answers. But the number one answer, I wish I'd have kept a record, how many fat people are present in the USA. There's no other nation like it. Nearly 100,000 cattle are slaughtered every day in the USA, yielding 60 million pounds of red meat. We have 260 million people in the USA, 100 million cows, and we kill 100,000 of them every day. And we do it differently than any other nation in the world, of course. We take these cows in their last 6 months of life and bring them into these feedlots, and there give them 20, 25 pounds of grain of soybean every day. And why do we do that? We do that, of course, to make them fat. And then we eat them. And then they eat us. And that's the way it is. We also kill about 250,000 hogs every day and eat 4 million pounds of bacon. Bacon is 85% pure fat. If you don't know what it is, make a hot dog out of it, and we eat about 47 million of them every day. Dairy cows yield 47 million gallons of milk. We eat 170 million eggs every day. Folks, if you're a chicken, don't walk into the USA. We kill about anywhere from 9 to 12 million every day. We eat 50 million pounds of sugar every day, an average of 21 teaspoons apiece. 21 teaspoons apiece. Can you imagine waking up in the morning, looking at your bedside table, and seeing 21 teaspoons of sugar on the bedside table? These processed foods we all eat are loaded with sugar, and they're loaded with salt. We drink 16 million gallons of beer and ale each day, and 1.5 million gallons of hard liquor, enough to make 26 million Americans thoroughly drunk every day. We still smoke 85 million packs of cigarettes a day. I'm proud to say that physicians are down to 9%. I heard recently in the USA that medical students were down to 2%. I like this statement by William Collins. He says, the carnivore animal has almost an unlimited capacity to handle saturated fats and cholesterol, whereas the vegetarian and herbivorous animals have a very restricted capacity to handle these food components. It is virtually impossible to produce atherosclerosis in the dog, even when 100 grams of cholesterol, now that's 200 times the usual daily human dose in the USA, plus 120 grams of fat are added to its meat ration. In contrast, adding only 2 grams of cholesterol daily to a rabbit's chow for 2 months produces striking fatty changes in its arterial wall. We more like the rabbit or more like the dog? Well, let's look at that a little closer. Here's some characteristics of carnivores and herbivores. Now, when you look down at your appendages, do you see claws? Or do you see hands we're supposed to be using for gathering those fruits and vegetables we're supposed to be eating? Now, there's some people who argue that the teeth in front of our mouth, yeah, they're sharp, so we're really omnivores. But most of our teeth are flat for grinding those fruits and vegetables. Now, intestinal tract, of course, is very long. Small intestine, 26 feet. Approximately. Intestinal tract of a carnivore is very short. You give your dog or cat something to eat, they got to go outside in a few minutes and do their thing. Now, when you cool your body, do you pant or do you sweat? When you drink water, do you lap it or do you sip it? Can you make vitamin C yourself like a carnivore can? Or do you depend on your diet? Folks, I think we're one of these, and we certainly act as if we're one of these. But I would suggest, basically, as a lot of other people have, that we really aren't. Now, if we could divide us into this room into 2 groups and put the pure vegetarians over a long period of time against that wall, and put the meat eaters, which most of us are, against this wall, and ask the simple question, what diseases do those pure vegetarians over there not get that these meat eaters get? Well, atherosclerosis, they don't get them over there. It's going to kill 50% of the people in this column over here. Systemic hypertension, not a problem in pure vegetarians. 60 million Americans have systemic hypertension. That's a blood pressure greater than 140/90. And that's an elevated pressure in and of itself, in my opinion. The normal blood pressure at birth is 90/60, and in saltless societies, it's 90/60 for a lifetime. The pure vegetarians don't get cancer of the colon, cancer of the breast, 2 of the 3 most common cancers. There was a news item last week or this week saying that the heavy meat eaters have a much higher frequency of cancer of the prostate than the light meat eaters. The pure vegetarians don't get diabetes, that is adult onset after age 50 or so. The pure vegetarians are not obese. They don't get peptic ulcer, constipation, hemorrhoids, diverticulosis, appendicitis, hiatal hernia, irritable bowel syndrome. Gastroenterologist, general surgeon, be out of business if we were pure vegetarian. They don't get gallstones, kidney stones, osteoarthritis, osteoporosis, salmonellosis, trichinosis. Can we change our health? Of course we can. When we pull our chair up to the table 21 times a week, we, for the most part, determine our health. Now, are we going to make that message clear to the American public? Or are we going to go on in our usual lifetime? Are physicians going to be the example or not? When we quit smoking, the non-physician community followed us very well. And I think when we alter our eating habits, the rest of the USA will follow us. And if we don't, nobody else will. This slide came from the Harvard School of Public Health. It has to do with body weight and when we die. They call it mortality ratio. Here on the horizontal axis is the weight. Whether you're a man or whether you're a woman, the more you weigh, more we weigh, the sooner we die. Now we can all point to Winston Churchill's and all the exceptions. But if you deal in groups of 100, and in all this stuff you have to deal in groups of 100, the more we weigh, the sooner we die. It worked with my right hand, it didn't work with my left hand. Now, as you know, in World War II, there were certain countries, people living in them, that didn't have much butter, and they didn't have much cheese, and they didn't have much red meat, and they didn't have much milk. And what happened to the cardiovascular death rate during that period of time, 1939 to 1945? Well, in Sweden, boom, it fell. In Finland, boom, it fell. In New York, Norway, boom, it fell. In the USA. It just kept on going up. Can we change our health? Of course we can. Are we going to change it by ordering more nuclear cardiologic tests and more MRIs, or by changing what we put on our tables? That's the fundamental question, in my view, facing American health. Now, this is a slide from the JMA about 2 years ago. It has to do with cancer of the breast. Now, why is he talking about cancer of the breast? What we see here is the frequency of cancer of the breast, death rate from cancer of the breast, in adults in these various countries. And on the horizontal axis here is the fat consumption, grams per day, by adults in those populations. Here's the USA, about 140 plus grams of fat a day. We have one of the highest frequencies of cancer of the breast in the world. Now, this could be cancer of the colon. The lower the lower the amount of fat intake in a society, the lower the frequency of cancer of the colon. And of course, this could be systemic hypertension. The lower the frequency of fat intake, the lower the blood pressure. And of course, it could be systemic hypertension. Can we change our health? Of course we can. Now, this is the American Heart Association slide, which suggests that the American Heart Association wants us at step 1 to reduce the amount of fat in our diet from 40% down to 30%. That'd be very good. The wonderful article in the New England Journal of Medicine, published April 29 by Huntinghack, showed that if you did that, beautiful study, you lowered the total cholesterol and lower the LDL by how much? What? That's exactly right. 5%. Previous studies had shown 8% and so on. This was a wonderful study. 5%. If you gave those people, whether they lowered their percent of calories from fat or not, a lipid-lowering agent, it dropped the LDL by 27%. In other words, if you're going to drop cholesterol levels by fat, you got to do it more than 30% of calories from fat. If we could knock it to 20%, we would make a tremendous impact on this nation. And I don't think it's something that we can do gradually. I think diet change has to be just like cigarette smoking. You either decide to do it or you don't do it. I changed my diet, boom, just like that. I'm a happier man now by doing so. But it's not a big deal, it's what you get used to. I used to sit down at the table and take a salt shaker and just cover everything I ate with a salt shaker. And all of a sudden, my blood pressure started going up a little bit. I said, I'm going to quit this stuff. I threw the salt shaker away. I can't stand the stuff now. It's what we get used to. My blood pressure came right down. We can do the same thing with fat. Now, these are the lipid-lowering agents that are presently available. I think they're great drugs. They're wonderful drugs. Compared to the toxicity of atherosclerosis, the toxicity of these drugs is nothing. The toxicity of lovastatin 20 milligram tablet is no more than placebo. Pretty important, pretty impressive thing. Probably 5% at max of the U.S. population with total cholesterols over 240 on a lipid-lowering drug. Max. Now this is a coronary artery in a patient who had angioplasty. Here the balloon went off. Here, boom, cracked that plaque, build dissection. I think all these people have a dissection if you have a good result. I think the internal elastic membrane is the strongest little thing in our body. It's wonderful. Good result at angioplasty, but the plaque's still there. Now, I think this lovastatin study after angioplasty, people are going to get the wrong result. It's not going to affect restenosis, but it's proven to affect areas where trauma did not occur. If I had angioplasty, folks, I guarantee you I'd be on lipid-lowering therapy. Now here's a saphenous vein. And in the last 5 years of this patient's life, this saphenous vein was not down here in the leg, it was in the aortico-coronary position. And here we are 5 years later, the same old thing. The lumen of this now new coronary artery is filled up with atherosclerotic plaque. Angioplasty is not enough. Bypass is not enough. 25% of the Americans who have bypass operation gain weight in the first year after bypass. 25% their cholesterol levels go up rather than down. I think bypass operation is a wonderful procedure. My son is a fellow in cardiovascular surgery. I'm very proud of him. I think it's a good procedure. I think angioplasty is a wonderful procedure. But I'm going to try to put all of them out of business. We don't have to have it if we change our existence. Now this is the best slide I've got right here. What we see here on the horizontal axis is the cholesterol levels, the total, and here's a relative risk of developing an atherosclerotic event. The line on the right here is primary prevention. These are people who've not had an atherosclerotic event. On the left are those who've had an atherosclerotic event. And what this slide shows is no matter where you start on the line, the more you lower the total cholesterol level, and specifically, of course, the LDL cholesterol level, the greater you reduce the risk of developing the first atherosclerotic event or a subsequent atherosclerotic event. Take these people with primary prevention. If they have a total cholesterol of 310, if you get that down to 270, you lower the risk of an atherosclerotic event 8 times the average to 4 times. If you get it down from 270 to 230, you take it down from 4 times the average to 2 times. Even if you've had an atherosclerotic event, if you start here at 230, if you get it down to 190, you lower the risk of a subsequent event by 2 times. It pays wherever you start. If you're alive, it pays to lower that level. This is my last slide. This slide comes from coronary arteries at sites of maximal narrowing in a woman 103 years of age. This is her left main coronary artery there, beautiful. I'll trade with her right now. This is her right, the biggest plaque in her body right there. This is the left anterior descending, beautiful. 103 years of age. I don't think atherosclerosis is a degenerative disease. We don't have to have it just because we get older. I think we are the degenerates, not the disease. This poor woman was run over by an automobile. Thank you for holding LDL cholesterol approximately 5%. If you give a 20 milligram tablet of lovastatin, you add 27% to that, lowering. Now, there are some people who walk in your office, I'm sure, that are 65 or 60, and they say, now look, doctor, I'm not that happy a man. Now, you tell me to change my diet. There are just a few things in life that make me happy. One is eating. And don't you have a pill that can lower my cholesterol level? There are just a few things I'm going to do on my own. Well, the answer to that question is yes. You do have a pill. And one of these HMG-CoA reductase will lower that total cholesterol. One pill, one 20 milligram tablet of pravastatin, one 20 milligram tablet of lovastatin, or one 10 milligram tablet of simvastatin will lower that LDL by 27%, irrespective of a change in your fat intake. Now, that ain't bad. And if you add a little nicotinic acid to that, or if you add a little bile acid resin, you can do a lot better than that. And I was talking to the Upjohn people the other day. Cholesterol is going to come out in 1 gram pills next year. So you can give these people 4 grams of cholesterol in a pill next year. It's not such a big deal. And that is a synergistic effect. I think all these, I don't say this lightly. You know, a lot of people say, well, my patients can't afford these lipid-lowering things. Well, they seem to be able to afford a bypass operation, or an angioplasty,
Or cigarettes.
or cigarettes, or a 16-ounce steak. I mean, last year we spent $18 billion on bypass operation alone. Now, a health care bill was something like $850 billion. But bypass operation alone was 1% of the gross national product. Not of the expenses of medicine, but of the gross national product of the entire nation. Angioplasty was $9 billion approximately last year. These drugs, you know, you could give all 7 million people in this country with symptomatic myocardial ischemia 1 HMG-CoA reductase, and it would cost $3 billion a year. So in contrast, it's chicken feed. Yes?
I'd like to ask you a question on something which you touched on but didn't cover. Was what do you think triggers the event that causes the myocardial infarction? You mentioned rupture.
I don't know. As far as I'm concerned, there's been too much focus on what was the final event. What was the thing that triggered the thing? The one thing we know absolutely unequivocally is that these people who have atherosclerotic event, it takes a god-awful lot of atherosclerosis, and they have a huge amount of it. They may or may not have a ruptured plaque. Some do, some don't. The sudden death victim, the unstable angina victim, usually don't. Most of the people who are talking about ruptured plaque haven't looked at a coronary artery in 25 years. I'd be very careful with that thesis. It may be right, may be perfectly right, but it's chicken feed. It's not getting at the problem. The problem is preventing the plaques, not preventing rupture of the fibrous capsule, in my view. Yes?
I guess I'm a little disturbed by that you're saying that somewhere between 60 and 90% of the problem is caused by dense fibrous plaque. 5 to 10% is caused by lipid. What can we do to prevent this 60 to 80% problem, not this 5 to 10% problem? I mean, it's kind of like we're trying to just skim off the top. I guess that's my problem that I have with your cholesterol theory, that there's just this little bitty thing you were just trying to prevent. I mean, most studies have shown that 90%, you have to have more than 90% narrowing of coronary arteries before you reduce the flow at rest. Certainly it's not true with exercise. I guess I'm not sure that I buy all this.
You buy what?
Well, that cholesterol is that big a problem if you're saying the rest of it is fibrous, dense tissue that's producing these 80% occlusion.
Well, the one thing that is sure is the people that have total cholesterol levels 150 for many, many years, they don't get these plaques, irrespective of what the plaques consist of.
Well, how many of those people have you looked at?
You
How
know,
many 50-year-olds with a cholesterol of 150 have you looked at?
there are not many in this country.
Well, I mean, that's my question. I'm not sure that we're really talking about the same thing.
Well, I'm talking about the most common cause of death in this country. And those people who die, and we attribute that to myocardial consequences, have god-awful amounts of coronary narrowing. Now, if you look at people who have chest pain or myocardial necrosis or myocardial scarring who die, their coronaries look bad if they don't. I forgot which I said, but if you've got a scar in the heart muscle, you've got bad coronary disease. If you've got necrosis, in general you do. I went to Kampala, Uganda in the 60s. I probably studied 500 hearts of people over there. They have big hearts. Systemic hypertension is devastating Central Africa. Big hearts. I didn't see an atherosclerotic plaque in a week. Their total cholesterol levels were 130, 120, 110, 90, 140. The average total cholesterol of a vegetarian is 140. Now, your question is, well, certainly cholesterol could not form a fibrous plaque. Is that correct?
I don't know, I'm asking you. You're telling me that that's the major cause of narrowing in the vessels that you diagnose.
I'm saying that's what plaque composition is in people with fatal coronary disease. Now, there are a lot of studies that show a big connection between thrombosis and cholesterol levels. It's a big deal. The higher the cholesterol level, the greater the clotting tendency. The lower the cholesterol level, the thinner the blood. I tend to think that the way the cholesterol is really working is by turning on the clotting process. You can take an animal, a non-human animal, and stick a catheter in the femoral artery and put it in the aorta and twist it all around, and it'll knock off all these endothelial cells. Now, if the cholesterol level, like in a rabbit, is 90, the platelets form right on top of those denuded endothelial cells, and within 3 days, the endothelial cells have grown back underneath, and it's smooth and clean as a whistle. On the other hand, if you take a rabbit and make them and give them a high cholesterol, high fat diet for a period of time, produce atherosclerosis, and then stick that catheter in the aorta and roll it around and take off those endothelial cells, then you get big plaques formed right on top of those denuded areas. So the connection between cholesterol and clotting and plaquing is a major one. Now, I think that these plaques probably are not predominantly fibrous tissue earlier in life. I think there's something else earlier in life. Yes,
Have you ever
ma'am?
looked at them with intravascular ultrasound, or do you have only autopsy studies?
Autopsy. I think that I'm all in favor of this intravascular ultrasonic thing because, number one, you're talking about cross-sectional area narrowing, not diameter reduction. So you know what thickness of the wall is. So you get a better, I heard one of the great echocardiographers about 2 years ago giving a talk at a national meeting and was presenting a paper on ultrasound, intravascular ultrasonic imaging. The first statement, by golly, coronary atherosclerosis is diffuse. This was one of our leaders. Now, what he was saying is unless you can show it clinically, it's not there. Now, the first describer of hypertrophic cardiomyopathy was a pathologist. And he said the ventricular septum is much thicker than the left ventricular free wall. That didn't mean anything to anybody until the echocardiogram showed it. And then, by golly, it was real. Yes?
I'm a surgeon, and quite often the coronary arteries are so bad you have to do an endarterectomy. I often wonder, the endarterectomized segment, does it behave more like a native coronary or like a vein bypass?
Yeah. I'll tell you a terrible story. There was a surgeon at NIH, my dear friend Chuck McIntosh, who used to do endarterectomies in the right coronary artery. And the first one that we had was This patient, he had done the whole right coronary artery. We had this unbelievably beautiful specimen, the whole thing. I was going to show it tonight, but I changed my talk here. And then this patient died 5 years later. So this was going to be the first time we ever looked at again, late. And the Technicon machine blew up that weekend. So we didn't destroy this thing. But we subsequently studied 2 or 3, and those things fill in by absolutely perfectly uniform fibrous tissue. Perfect, it's beautiful. But they do fill in. Now, if you could knock their cholesterol levels down to 140, would they fill in? I mean, to me, this endarterectomy is a magnificent procedure. It's not really an endarterectomy, you know, it's an endarterectomy and a mediectomy too. You get a little media out of there. But it's magnificent. I mean, you see just the tube. It's beautiful. Now, I'd like to see that procedure done and at the same time take those patients and just blow their cholesterol out. You know the best way to lower cholesterol? Is put somebody on cardiopulmonary bypass. It'll take it from 250 down to 120, and it'll stay there for a couple of weeks and then gradually come back. I mean, if you could just have continual cardiopulmonary bypass, the problem would be over.
I'm a surgeon, I say that. Oh my God. Hard on him. He's destroying himself. You know, one of the things we did was we kind of sent a bunch of data off, not realizing what we'd sent to some statisticians, and one of the things they came back and told us was that those patients who had cholesterols above 300 had a much lower mortality than the ones that were below 200. And that was just for the 30 days after surgery, so it's not long term. But it made you wonder whether people with really low cholesterols may not be malnourished a little bit, and
I don't
seem to have
think
a
so.
disadvantage.
I don't think so. I mean, real low, 200 is not real low. As a matter of fact, we published 2 papers last year that from 2 different groups, and these are people who had angiographically proven coronary disease. And 50% in each group had total cholesterols less than 200, like 190, 185. And the major reason for that was their HDLs were quite low, 20, 25, 15. There's no question HDL is important. I think you surgeons have a magnificent opportunity. And I think when you've got a patient in the bed and you can dangle a scalpel over their face and you tell them that, you know, you've got to eat this diet and you've got to take this drug and you've got to lower the cholesterol level and you can let it slip down if you handle it a bit, that you can have quite an influence.
We've got the best stop smoking record going. About 60% of the smokers quit. That's better than any other plan that's out there. So we haven't done very well with diets.
I think that's good. Well, you're not going to do very well with diets. That's the point. Now, when you take that, when you see that 75-year-old woman out there driving a Volkswagen, you know you're dealing with a flexible person and you make a change. But most of us are not going to change. And these drugs will change us. And I'm in view of anybody with symptomatic myocardial ischemia, bypass, angioplasty, put them on the drug. And then with time, you can work on the diet. And you're not going to change the diet until your diet changes. I'm not talking to you, but I'm talking to everybody.
What about age?
What?
Age.
Well, age is important, of course. I mean, my mother's 91. I don't care what...
Would you put her on Mevacor?
What?
Would you put your mother at 91?
No, that's what I'm saying. I didn't answer the question. My mother's 91, and I don't really care what her total cholesterol is. On the other hand, if she was 71 and playing golf every day, absolutely. Absolutely. A lot of people go to bypass at 71, 78, 79. To put that person on a lipid-lowering drug, oh, it's a big deal. It's not a big deal to go to surgery or angioplasty. Come on.
You showed us that the composition of the plaque changes with the degree of stenosis.
Yes.
However, it's not, coronary thrombosis doesn't always occur with the highest degree of stenosis. It's not related. How do you explain that?
That's what some people say. Well, I had a choice tonight of giving 2 talks, of just continuing on the coronary morphology or or giving a sermon. I chose the latter. Now, in the studies that we have done, at least were done in my lab, were done by primarily Frank Brosius. We did a study in patients with acute myocardial infarction at the site of the thrombus, asking the question, how much of total occlusion, how much of the lumen is obliterated by plaque and how much by thrombus? The average amount of lumen obliteration by thrombus was 19%, meaning that 81% of the obliteration was by plaque. So if you get max thrombolysis, we studied 50 people, you have an average elimination of 21% of the lumen. Now the problem with that study was that there was great individual variability. In some people, 67% of the lumen was thrombus. And in other people, 2% of the lumen was thrombus. So in an individual patient, you don't know. But the idea that it's the little plaques that are the most dangerous, not the big plaques. Well, you can have the little plaques.
But if you have both in the same patient,
Of course you're going to have both in the same
the
patient.
thrombus will always occur at the highest area of stenosis, highest degree.
Well, that's my experience. It's different from the angiographic people. But the angiographers, you know, they read thrombus by angiogram. They're pretty good. You can take a histologic section and show it to 5 pathologists, and they're going to disagree whether there's a thrombus or not. But the angiographer can throw it on the screen and say, that's a thrombus. And you'll believe it. It's pretty good. Yes?
I hear you advocating very strongly for secondary prevention, but
Yes.
when do you cross the line over to primary prevention in terms of medical therapy? Assuming again that you're not going to be able to change people's diet who haven't had anything.
Yeah. Well, it's a problem. I mean, I'm not oblivious to the problem. My first son has ears about that size. My third son has ears about this big. And if I can make my case to him, he say, that's logical, that's reasonable. I'm going to do it. Now, our first one, it doesn't matter what I tell him. He's going to do what he wants to do. Now, that's what we deal with. I mean, when I meet people, I try to see whether I'm dealing with a flexible person or not. One that's got good ears. Can they listen? Can they hear? Do they want to change? Are they rigid? And it's a problem. I think in primary prevention, of course, you have more time to deal with diet. And you can kick people in the shins, but you've got to be a believer yourself. And you can't be talking to these people at 30% over ideal body weight and expect them to follow you. It's a joke. You got to know what you're talking about. What percent of calories from fat do you eat every day? So you can talk to them in terms that these books talk about. And if you can't do that, we're not going to get our message across. I'm convinced. But there's no question, if you can get your percent of calories from fat down to 20%, I mean, the number of people going to need drugs is very small. If you can get it down to 15%, the guy in California, Ornish, those people are down to 6% of calories from fat. Now, you can't go in a grocery store and eat and buy food so you eat only 6%. I mean, it's impossible. Those people had to go into his clinic to get the food. But, you know, the Japanese historically have been at 10% of calories from fat. No wonder they're beating us. You don't go over there and see people up to here. We're killing ourselves. We're crazy. I have a simple regime. Number one, I don't eat between meals. Everything we eat between meals is high fat. A single potato chip is 10 calories. I rarely eat a dessert. I eat it once a week, and it's a special occasion. I like it. I eat eggs once a week, Sunday mornings, that's it. I don't eat, the only flesh I eat now is fish. I don't eat cows and pigs and chickens and turkeys and so on. I'm a happy man. I'm a happy man. I don't like all the killing. I really don't. I mean, you can look at this another way. You read these books by John Robbins.